The learning objectives of this talk are illuminate some core science related to renal tubules, to construct a general approach to pediatric tubulopathies, and to summarize the tubular point of error and segmental disorders. More than 1 century ago, Marconi is an electrical engineer, invented the first radio in the world, and he is considered the godfather of wireless telecommunication, which are using over the globe nowadays. That old radio is composed of main tuner and fine tuner. It's a metaphor to represent what happened in the renal tubule, because the renal tubule also has main and fine tuning. So the main tuning, which is the bulk reabsorption, happen in the proximal tubule, while the fine tuning happen in the distal portion of the renal tubules. And of course, all of these mechanisms require energy. For that reason, if there is any shortage of energy, the first organ to suffer is the kidney. One of the important pump in our body on the renal tubules depends mainly on energy is sodium-potassium ATPase, or simply we call it sodium pump. This pump is present in all basolateral aspects of tubular cells, in all tubular cells actually. And the main function of this pump is simply to extrude 3 sodium out of the cells and introduce or influx 2 potassium inside the cells. As you can see from this diagram that this sodium potassium ATPase pump is present in all segments of the renal tubule, starting from proximal to distal nephron. For that, sodium is considered the maestro of our body, and it controls all the function of the renal tubules actually through this pump. So this is considered as a chemical sensor when the ratio of sodium to water is making the osmolarity of our body. And this chemical sensor starts in our brain from the osmoreceptor in hypothalamus, and it talks with the kidney through the vasopressin hormone through the posterior pituitary. So if we sense that there is a higher osmolarity, increased sodium to water ratio, thirst and the antidiuretic hormone mechanisms start to work immediately. And both start to work after reaching osmolarity of 285. After that, both of them are still working, but the vasopressin has no effect on the osmolarity, still released from the posterior pituitary, but has no osmotic function after this 295 osmolarity reached, while drinking is still there. And for that reason, drinking is very important. And this is especially important in pediatrics because in infant and small children, they cannot express about thirst. And if you don't introduce water to them, they easily go to dehydration. On the other hand, water has a free access in our body and it moves among the cells freely, but on the kidney it's controlled by vasopressin or antidiuretic hormone, which is start to stimulate the cell from the basolateral aspect, and this will insert the water channels on the apical surface, which is aquaporin 2 receptors to bring the water from the lumen to inside our body when it's needed. Another important sensor, which is the volume sensor, present in the juxtaglomerular apparatus formed by the afferent arteriole and distal convoluted tubule, which this controlling the angiotensin system. And through this organ talks between the liver, lungs, and kidney, it end up with the mineralocorticoid aldosterone, which keep the salt and water in our body. Through this fine adjustment of sodium and water in distal nephron through antidiuretic hormone and the vasopressin, as well as the mineralocorticoids, we preserve our water and sodium in our body. Without that, we will lose a huge amount of salt and water. As you can see here in this diagram, that from 100% filtration through the glomerulus, the renal tubule will preserve 99% and eliminate only 1% of salt and water in the urine. Another important organ stock is to keep calcium and phosphorus in appropriate ratio and appropriate metabolism in our body. So the organs are talking through these three hormones: parathyroid, vitamin D, and calcitonin. Although calcitonin has no physiological role in our body until now, we don't know what is its real function in physiological state, although it has a significant and important pharmacological action used to treat hypercalcemia. This is the function of these three hormones on the kidney. So vitamin D or activated vitamin D enhances the reabsorption of calcium and phosphorus, while parathyroid hormone is very selective, so it reabsorbs calcium and extrude phosphorus out with the urine, and the calcitonin do actually the reverse of the parathyroid hormone. One of the most important portion of the renal tubule is loop of Henle, and this loop of Henle is actually composed of three portions. The proximal portion is thick, followed by thin portion, and this is followed by the thick ascending limb of loop of Henle, which is highly functional and highly specialized tube. This tube is helping in urine dilution and elimination of waste products, and introducing hypotonic fluid to the distal tubule. If this function is not working well, the distal tubule will understand that we don't need fluid and salt, so it will eliminate huge amount of salt and water with the urine. The loop of Henle doing this job through three mechanisms actually, because it is waterproof and is impermeable to water. So sodium and chloride reabsorption with the waste product is introduced to the distal element, and this is what we call this mechanism happens through counter current mechanism, which is a complex physiological mechanism. As we can see here, the thick ascending limb of loop of Henle is highly specialized cells with so many channels and specific channels for sodium, potassium, and chloride, and even calcium and magnesium. Magnesium is known as a forgotten ion because it usually doesn't give much attention to it, while it is the second most important cation in intracellular cation, and it's very important for neuromuscular stability. It reabsorbed in the kidneys in the distal portion rather than proximal, and this is done through two different mechanisms. One is paracellular and the other is transcellular. Paracellular is among the cells, so it happens in the thick ascending limb of loop of Henle, while the distal convoluted tubule transport magnesium transcellularly. Another unique issue related to magnesium, which is the reabsorption in the renal tubule compared to calcium and phosphorus. As you can see here, the calcium and phosphorus is mainly reabsorbed from the proximal tubules, compared to the magnesium, which is absorbed mainly in the distal portion of the nephrons. So the fine adjustment happen, the bulk and the fine adjustment happen in the distal nephrons, while in calcium and phosphorus, bulk reabsorption happen in the proximal nephrons, and just only fine adjustment happen in the distal nephrons. So this is something unique for the magnesium. So many classification for renal tubulopathies are there, and simply we can say that in pediatrics, mostly of tubulopathy is hereditary or genetic in origin, while in adult, many of tubulopathy is secondary to other acquired or secondary. But still there is a gray zone between pediatric and adult here about the genetics and hereditary tubulopathy, and also acquired tubulopathy can happen in pediatrics. When we think about tubular dysfunction, we need to look at the tube as the tubules as a tube. So it has something related to anatomy and something related to the lumen inside and something related to the environment around. So it may have anatomical dysfunction or functional dysfunction or an interstitial reason or intraluminal problem, all of this producing tubular dysfunction. But when you are talking about this topic today, is the renal tubulopathy, you are focusing more in the functional causes or primary causes of tubular dysfunction. Galen is the first one who used the term opathy, and it's a Greek term. It means that suffering or sick, and used in many things in medicine as a terminology. Of course, this has happened 200 years antedate, and now still in the using this in medicine. But recently, and in recent decade, we have two new terms of opathies, which is ciliopathies and channelopathies. So ciliopathy is found and in the literature, and it's simply responsible for maldevelopment of the organs, while channelopathy is also recently introduced and very complicated subject about ion dysfunction or functional error, point functional error in the renal tubules especially. And when we say tubulopathy, we are talking about primary dysfunction, as I mentioned. Insect explore its environment through the antenna, and this antenna has protrusion, finger-like protrusions called cilia or sensilla in insects. By this, the insect can decide how to go or how to direct their behavior. These cilia is also present in human body, and actually present in all of or most of our human body cells, and it's very complicated structure, which is sophisticated discussion in the last decade about composition of cilia and function of cilia in our body. But simply we have two kinds of cilia, which is motile cilia and non-motile cilia. Motile cilia is mainly for two things, two important functions in our body, which is respiratory system and reproductive system. In respiratory, it eliminates the dust and foreign particles away from the trachea. And in reproductive system, it's responsible for movement of ova and sperms. While the most important thing is the non-motile cilia, actually, which is responsible for cell proliferation and differentiation. By this also, it's responsible for left-right symmetricity and tissue morphogenesis. So for that, if there is any defect in the cilia, it may produce a malfunction or anomaly, especially in the kidney. This diagram shows how the ciliopathy affect the kidney and other syndromes through a very complex genetic disorders. And to summarize this, we can say that renal ciliopathy is present in kidney diseases like autosomal dominant and recessive polycystic kidney, nephronophthisis, and this is mainly renal or kidney problem, although it is still present in liver and other organs, while it's mainly kidney issue. Also, renal ciliopathy is a part of the syndromes shown here, that like Bardet-Biedl syndrome, Joubert syndrome, senior Loken, and Meckel-Graber. All of this has a kidney anomaly and producing even kidney failure, and usually presented with cystic kidney diseases. Another important and interesting topic in the literature is trafficking, and trafficking is simply how to carry the macromolecule from one side to the other side of the cell, passing through the cell. So it acts like a cargo for macromolecules by starting endocytosis and the exocytosis process and passing through the cell through a vesicles. This trafficking is very important in kidney and tubular disorder. As you can see here, three major diseases affecting the renal tubules happen through trafficking disorder: cystinosis, Dent's, and Lewy disease. Cystinosis mainly for retention of cystine crystal within the cells, producing the organ dysfunction not only in the kidney but in all over the body. While Dent's and Lewy disease is considered part of Fanconi syndrome or proximal tubulopathy, but this actually proximal tubulopathy, partial or selective, mainly for proteinuria, because it's not able to transport the protein and producing tubular proteinuria. Coming to channelopathy and membrane channel, there is a huge amount of diseases produced by channel disorder or channelopathy in the kidney. And we can summarize this here that renal channelopathy happened in Fanconi syndrome, Dent's, Bartter, Gitelman, East, Liddle disease, familial hypomagnesemia, hypercalciuria, nephrocalcinosis, pseudohypoaldosteronism type 1 and 2, and nephrogenic DI, all of this channel defect. Now we are going to look for generalized overview of the renal tubulopathy and then going specifically for each disease later. Discovery of renal tubulopathy requiring high index of suspicion is indeed, and the genetic diagnosis usually come from family history or detection of the new case based on the biochemical changes, which has a specific pattern, and then we think in renal tubulopathy doing genetic test. So it needs a smart interpretation of the biochemical pattern. On the other side, radiology has a limited value. Presentation is different in neonates and infant compared to children. So coming to the neonatal and infancy presentation, we can find polyhydramnios antenatally or tiny baby with prematurity IGR. Mother can observe polyuria through changing diaper frequently. Babies can go for dehydration easily, but in this case with normal urine output, unexplained fever without focus, gastrointestinal symptoms in the form of constipation due to dehydration, vomiting due to electrolyte disturbance, failure to thrive and percentile deviation. Hypokalemia may produce wasting and weakness of the muscle. Childhood presentation is different because polyuria is sometimes or occasionally present as nocturnal enuresis. Short stature due to failure to thrive, eating habit, specifically salt lover or salt craving, rickets, which is not responding to vitamin D, hypokalemia and hypomagnesemia produce weakness and cramps. Blood pressure will be high in monogenic hypertension, and we'll come to this soon, and other organ may be affected due to the tubular and the inborn error of metabolism. There is more than 20 disorder has renal and renal tubulopathy with deafness. This is because of the common structure protein in both ears and kidney, especially the inner ear hairy process, and this mutation producing through ciliopathy and channelopathy proteins defect and producing these diseases. As we mentioned, image has limited value. The most important is nephrocalcinosis, nephrolithiasis, and rickets. Sometimes we have pylectasia, dilatation of both renal pelvis due to polyuria, or structural abnormality leading to tubular dysfunction, delayed bone age because of poor growth. When we see metabolic acidosis with low bicarb hyperchloremias with normal anion gap, mostly you go for renal tubular acidosis, but actually in practice it's not very common in pediatrics. The most common things related to giving this metabolic pattern is the high chloride load or increased saline in IV fluids, or bicarbonate loss with persistent diarrhea. Looking to metabolic alkalosis, we need to combine this metabolic pattern with two things actually, which is aldosterone, renin from one side and the blood pressure on the other side. So when have a metabolic alkalosis, look for aldosterone and renin. If aldosterone is high and renin is low, this reflecting hyperaldosteronism. If both of them is low, this is going with monogenic hypertension with one exception. I will tell you about this soon. When both of them are high, this is going with Bartter syndrome and renal artery stenosis or renovascular hypertension. To differentiate Bartter from renovascular hypertension, blood pressure here is important because Bartter is normotensive and renal artery stenosis is hypertensive, of course. The exception here is the glucocorticoid remodeling aldosteronism, which is one of the monogenic hypertension disorder. Here, the aldosterone is similar to the hyperaldosteronism state. This biochemical pattern, also hypokalemic, hypochloremic metabolic alkalosis, who happened in Bartter syndrome. It also may happen in other condition, which is called pseudo-Bartter. And here we can see what can produce pseudo-Bartter pattern in electrolyte, but it's not Bartter syndrome. In neonates, especially prostaglandin treated for to keep the PDA open in congenital heart disease, and the mother with eating disorder also may have the pseudo-Bartter picture. Management of this condition is mainly for general management, which is mainly fluid and electrolyte replacement. While focusing on nutrition and growth is very important, and sometimes hypertension requiring antihypertensive medication and calcium may be needed for calcium for activated calcium. Another specific treatment for some conditions like cystinosis, you can give cysteamine to treat this, and Bartter syndrome, non-steroidal anti-inflammatory medication. Monogenic hypertension treated with potassium-sparing diuretics, as you can see later. Nephrogenic DI with hydrochlorothiazide, and congenital hyperplasia with steroid. Now we are talking about special segment and the disease in each segment. So in the proximal tubules, we have isolated defect, renal tubular acidosis, isolated glucosuria or phosphaturia, and this phosphaturia producing familial hypophosphatemic rickets. Selective one or partial proximal tubular dysfunction present in Lewy disease and Dent. We'll come to this. And the generalized one is Fanconi and Fanconi-Bickel syndrome. The main difference between Fanconi and Fanconi-Bickel syndrome that in the last one, Bickel syndrome, has hepatomegaly and hypoglycemia. We talked about trafficking before, so this is the disease affected by trafficking defect. Renal tubular acidosis has two main types. One is the proximal and one is the distal part. So the proximal one is responsible for due to bicarbonate defective reabsorption, while the distal one is a defect in secretion of hydrogen ion. And we have four kinds of renal tubular acidosis. The distal one associated with nephrocalcinosis, proximal associated with we can still acidify the urine because the distal mechanism is intact. So pH of the urine can be decreased below 5.5 with acid load. Type 3, which is a mix of 1 and 2, present uniquely in the osteopetrosis. And type 4 is due to pseudo-hypoaldosteronism or true hypoaldosteronism. Fanconi syndrome is described initially by the Tony Debris Fanconi, this team which described collectively the Fanconi syndrome, but at the end it is assigned to Fanconi, and Fanconi described proximal renal tubular acidosis with hypokalemia, proteinuria, loss of amino acid and glucose, and also phosphate. So it's a proximal generalized tubular dysfunction. The cause of Fanconi syndrome is huge. For pediatrics, we are focusing more on the inborn error of metabolism shown in this list, but there is also another causes for the Fanconi syndrome through drugs and structural functional defect. All of these can produce Fanconi syndrome. The most important for Fanconi syndrome is cystinosis, and cystinosis is one of the most common reason for inborn error of metabolism producing Fanconi. It's present in the first 2 years of life and producing end-stage renal disease by the first decade. The children may present with photophobia, and crystals appear in the cornea after the second year of life and can be detected by slit lamp examination. Treatment is cysteamine. Dent is a selective Fanconi with proteinuria associated with hypercalciuria and nephrocalcinosis, but it's limited only to the kidney compared to the Lewy disease, which is selective Fanconi proteinuria as well, but it has some extrarenal manifestation, mainly cataract or glaucoma and learning difficulty in neurologically. For the loop of Henle, Barta described this disease in 1960s, but nowadays we have 5 variants of Bartter syndrome, depending on the channels affected. So first two types, 1 and 2, is called neonatal Bartter or hyperprostaglandin E syndrome. And the difference between type 1 and type 2 that in type 2 we may have hyperkalemia during neonatal and the early few months of life compared to hypokalemia in classically known in Bartter syndrome. The classic Bartter happened in childhood, not in neonates, and presented with salt carving, and type 4 associated with deafness, type 5 associated with hypocalcemia compared to others. Bartter syndrome is treated with non-steroidal anti-inflammatory plus supplements. The hypomagnesemia producing 2 diseases here is known depend on the site of action. So we have familial hypomagnesemia, hypercalciuria, nephrocalcinosis, and Gentleman syndrome. And the main difference between these 2 is the calcium. This familial hypomagnesemia is present in toddler and usually associated with extrarenal manifestation like myopia and nystagmus. Calcium sensor present in the parathyroid gland, producing other diseases other than type 5 Bartter syndromes like these diseases. Coming to the distal nephrons, we have so many channels on this sophisticated part of the renal tubules. Actually, this is the origin embryologically coming from 2 different sites, nephrogenic blastema and ureteric bud connected at this area, so producing the sophisticated distal renal tubules, and a lot of channels are there. One of the unique channel is the sodium chloride channel, which is a thiazide sensitive channel. If present on the epithelium of distal tubule, if there is defect in this channel, Gentleman will appear. While there is gain of this channel, Gordon disease or pseudo-hypoaldosteronism type 2, and Bartter 3 and East syndrome present on other channels of the distal tubules. So Bartter 3 is normomagnesic hypercalciuric, while Gentleman is the reverse, actually, hypomagnesic and hypocalciuric. Bartter can present antenatally in neonates, while Gentleman in older children. So this is the Gentleman syndrome associated with hypomagnesemia and hypocalciuria. Gentleman is actually like thiazide diuretic action, producing a lot of similarity in electrolyte disturbance. Gordon syndrome, pseudohypoaldosteronism type 2, is a mirror image of Gentleman syndrome. So we may have metabolic acidosis, hypercalcemia, hyperkalemia, and hypercalciuria, and most importantly, hypertension, of course. For this reason, we treated with thiazide diuretics. East syndrome is the same like Gentleman syndrome, hypokalemia, metabolic alkalosis, hypomagnesemia, but it also has extrarenal manifestation. And from this term, we call it East: epilepsy, ataxia, sensorineural deafness, and tubulopathy. The seizure present early in life is not related to electrolyte disturbance, but related to the neurological insult. Finally, the collecting duct is the site of hormonal action and fine-tuning of sodium and water, especially acidosis as well. So we remember that water here is presented from the vasopressin on the basolateral aspect of the cell and producing aquaporine channels on the apical surface. Again, there is what we call epithelial sodium channel, is the site of amiloride action, which is a potassium-sparing diuretic. It happens through the mineralocorticoid on the basolateral aspect and introducing these cells on the epithelial site. Any defect on these cells producing pseudohypoaldosteronism type 1, and any gain in this channel producing the Liddle disease. Liddle disease is related to the endocrinologist Liddle, and he discovered so many things other than Liddle. And the Liddle disease combined with these two rare diseases, which is glucocorticoid remediable aldosteronism and the apparent mineralocorticoid excess, is this is a group of monogenic hypertension. But also collecting duct is affected, channel defect producing nephrogenic DI and pseudo-hypoaldosteronism type 1. Pseudo-hypoaldosteronism type 1 is a salt wasting condition. It has two types, autosomal recessive and autosomal dominant. The autosomal recessive actually is severe with some extrarenal manifestation, mainly cystic fibrosis and skin lesion, while the dominant one is milder and self-limiting. This is the two channels affected in pseudohypoaldosteronism type 1. And this is the salty baby, which is related to defect in salt wasting condition in pseudohypoaldosteronism type 2, the severe form of autosomal recessive form. Actually, these three conditions, Liddle, GRA, and AME, is a mirror image of pseudohypoaldosteronism type 1 biochemically. Monogenic hypertension is this group who is coming from oversensitization of epithelial sodium channel Liddle syndrome, and also including Gordon syndrome, pseudohypoaldosteronism type 2 in the distal nephron, a distal convoluted tubule. Apparent mineralocorticoid excess, it may occur early in life, so producing IUGR and neonatal hypertension. Treatment of this condition is mainly by potassium-sparing diuretics, so we can see that Liddle and apparent mineralocorticoid excess is treated with amiloride, while GRA is treated with cortisone. Although it is excess on glucose, cortisone, but glucocorticoid will suppress the ACTH in the brain and treat the condition. Pseudo-hypoaldosteronism type 2 is treated with thiazide diuretics. Finally, water fine-tuning happen in the collecting duct. Any defect on this producing the nephrogenic diabetes insipidus. And nephrogenic diabetes insipidus producing polyuria dehydration, presenting with polyuria dehydration, fever, and constipation with this biochemical pattern. And the diagnosis mainly now by paired urine and serum osmolarity, but still we may require the water deprivation test and to differentiate between the nephrogenic and central DI. And the treatment is a combination of hydrochlorothiazide, indomethacin, and amiloride. This is finally to summarize the point of error happened in tubulopathy. And just to remember these few things, that sodium is a maestro and water has a free access. Distal nephron is the fine tuner and loop of Henle is the main filter. Diagnosis is based on high index of suspicion. Ciliopathies and channelopathies may explain this error. Management is mainly replacement, salt and water, or electrolyte and water. Malmanagement affects the growth in children. Monogenic hypertension is usually treated with diuretics rather than antihypertensive medication.